Good afternoon. Welcome to Grand Rounds today. As usual, I will ask you to sign the attendance record at the back of the auditorium and also to fill out the program evaluations and give us any ideas that you might have in regards to future topics or future speakers. Also wanted to remind you that we will not be having Grand Rounds next Wednesday or the following Wednesday, and that we will then reconvene after the first of the year with our next Grand Rounds program. I don't know if you realize this, but the CME program here at Mary Greeley doesn't accept financial support from any drug or device makers. And so our ability to provide these CME programming here is dependent on financial support of non-pharma groups. And these groups include First American Bank, who's been very generous in its support of the CME program. Periodically, I like to take the opportunity, including today, to thank First American Bank, and also today I was going to introduce Jim Gibbons and Rex Rorson, who had a couple of introductory remarks prior to our beginning the program. So please join me in welcoming Jim and Rex.
Thank you, Dr. Hellberg, and we just want to express to all of you our appreciation for being a part of this event. I'm here with Rex Rorson, our loan originator at a mortgage loan originator at First American. So. Really excited. You know, we've been sponsoring this program for the last 5 years. You know, we really believe in what happens in this room. You know, for any great organization to be successful, it depends on the ability to share information and ideas. And being involved in this information sharing process is something that we believe our role as a community bank is all a part of. We respect and appreciate our relationship with the medical community. And we have good news for Andrea. We are planning on sponsoring this event again, Grand Rounds again, in 2016 at the same level. So, like I said, we appreciate what you do here. We're going to be involved with you going forward, and we just, respect all you do and for our medical community and our citizens of this county. Talk to you soon, right? Yeah.
Our presenter today is Dr. Travis McKenzie. Dr. McKenzie is a board-certified general surgeon. He did his postgraduate training at the Mayo Clinic and then subsequently at Mass General and Brigham and Women's. He currently is assistant professor of surgery at the Mayo Clinic, and he battled the headwinds today driving down from Rochester to update us on bariatric surgery. So please join me in welcoming Dr. McKenzie.
Thank you. Thank you very kindly, and thanks for allowing me to be your guest today and talk to you about something that I'm certainly very passionate and interested in, and I think it's a very relevant problem that I'm sure all of us face, and that's obesity. So I practice both endocrine and metabolic surgery. About half of what I do is classical endocrine surgery, including thyroid, parathyroid, adrenal, and pancreas surgery. And about half of what I do is also what's considered bariatric or metabolic surgery, which includes some of the operations I'm going to speak with you about today. So the outline for the discussion today is going to be to define the obesity epidemic and put some statistics on that for you to sort of frame the problem, define who is a candidate for bariatric surgery, and describe the relevant procedures that are done today in 2015 and what are some of the complications and what are the outcomes from bariatric surgery. So we're all sort of speaking the same language, just a short update. We classify obesity based on BMI category, generally speaking. It's not always the best categorization, but it's the best one we have currently. Normal weight is BMI less than 25, overweight being 25 to 29.9, obese greater than 30, and extreme obesity or class 3 obesity is greater than a BMI of 40. And I'll be referring back to these numbers throughout the talk. So obesity and its related medical comorbidities are a serious worldwide health crisis, so not just the U.S., but worldwide. At present, bariatric surgery really offers the only reliable and durable remedy for obesity and these related complications. In the U.S. alone, 67% of adults are overweight, so BMI greater than 25. That's 97 million people. That's a very staggering statistic if you think about it. 31% of adults are obese today, BMI greater than 30. 10% have class 3 obesity or a BMI greater than 40. When you look at this topographic map from the CDC looking at 1985 to jump ahead to 2008, it's very clear that there's a rampant increase in the amount of obesity that we're seeing today. This is the statistic from 2014, and I highlighted Iowa there for you. 30.9% of patients are obese, BMI greater than 30. No state has a less than 20% prevalence of obesity. 19 states actually have a prevalence of 30 to 35%. And unfortunately, we live somewhat in the obesity belt. The Midwest has the highest prevalence of obesity, 30.7%. This is not just a problem that is within one category of patients. It sort of transcends ethnic boundaries. You can see here prevalence among African Americans are in the generally 30s, 35% for obesity. This is also a global problem. This graph here shows the percentage increase from baseline from 1986 to 2011 in regards to these various BMI categories throughout the world. And unfortunately, the BMI category greater than 50, so the extreme obesity category, is increasing faster than any other category. Greater than 1,000% increase from baseline, and still increasing. So how does the U.S. size up? You can see there, unfortunately, we are leading the pack in obesity with 31% of our population being obese. This is also a childhood problem, not just adults. It's a male problem, a female problem, a childhood problem. 17% of our adolescents are currently obese. That's 12.7 million children. So this is a problem that's going to continue to grow and expand. Obesity is extraordinarily complicated. There's kind of a stigma on obesity that we all understand and know of, where obesity is just really being large. Why don't you just get on a treadmill or an exercise bike and it's gonna solve itself? That's not really the case. The actual causes of obesity are very obscure at this point, but we know it's multifactorial. There are genetic factors involved, physiologic metabolic factors, social factors, behavioral factors, as well as cultural factors, so extraordinarily complex. Currently, we live in the era of the perfect storm. We have unfavorable genetics that predispose us to obesity. We live in an era of reduced physical activity where most of us are strapped to an iPad or an iPhone most of the time with limited amount of exercise or activity. And we have cheap, plentiful, and very tasty high-calorie foods that are easily accessible. Obesity, as I mentioned, is much more than just being large. It's much more than just size. Pretty much every organ system in the body is affected by obesity. There's increased incidence and prevalence of cancer and other medical comorbidities with obesity. This graph here just demonstrates as BMI category increases, so do the various medical comorbidities. So to outline a few, asthma, diabetes, which is very important, and we'll talk more about that later in this talk, obstructive sleep apnea, hypertension, and the list goes on and on. Obesity causes death. Greater than 400,000 preventable deaths in the U.S. are caused by obesity or related to obesity. That's second only to smoking. 75% of people with a BMI category greater than 40 or class 3 obesity have at least one comorbid condition that also affects livelihood and health. There's a much higher likelihood of premature death, and we'll also discuss that more. This is a very interesting graph that shows in-hospital mortality for patients who actually present to the emergency department with pre-infarction angina. What this shows is as BMI category increases, so does the risk of in-hospital death. Obesity is extraordinarily expensive on a socioeconomic platform. National estimate of cost, direct medical cost, $147 billion. Obesity-related absenteeism from work alone, $6.38 billion estimated. Again, a staggering statistic. So what about bariatric surgery? I would argue, and I'll present some data, that it achieves meaningful and durable weight loss. It improves or potentially even cures most obesity-related comorbid conditions such as diabetes. It improves life expectancy. It improves the quality of life, very importantly. And it's also cost-effective. So who is a candidate for bariatric surgery, and where did these criteria come from? Most insurance providers go by the NIH criteria that were proposed in 1991. So a BMI category of greater than 35 with at least one relevant medical comorbidity, that patient would be a candidate for bariatric surgery, or BMI of 40 or greater without a medical comorbidity. What we do know is less than 1% of potential candidates, so patients who actually fit these criteria, actually undergo bariatric surgery. So we're really just scratching the surface on this patient population that really stands to gain from this potential therapeutic modality. These criteria, as I mentioned, come out of the NIH from 1991. A panel of experts reviewed data from open gastric bypass surgery, and that's very relevant. Back in 1991, this is before the advent or widespread use of minimally invasive techniques for bariatric surgery. So the risk they reviewed was actually quite high. Risk of hernia, wound complications and such, hospital stay, mortality, for instance, was much higher. So because of the risks involved with these bigger operations, surgery was limited to patients with a BMI category of greater than 35. The thought process being that we're taking actually healthy patients that don't need surgery per se and subjecting them to these medical risks. But there's a push among both the medical as well as the surgical communities to actually drop that threshold down to potentially less than 35 if there are relevant medical comorbidities such as type 2 diabetes. Since 1991, there's been an increased prevalence in obesity. There's been the introduction of laparoscopy, which has made the hospital stays much shorter and actually decreased the risk of surgery. There's been the demonstration that surgery improves quality of life dramatically, and data demonstrating cost effectiveness, and that's why there's been this push towards lower BMI categories. And I think ultimately we're going to start seeing that happen in lower BMI categories, that insurance providers will cover bariatric surgery. So let's talk a little bit about the current procedures that are out there today. I'm going to discuss the adjustable gastric band, the sleeve gastrectomy, and the gastric bypass. These are the three most common procedures performed around the country. At the Mayo Clinic, we do not offer the adjustable gastric band any longer based on some evidence that I'll discuss with you here in a moment. So looking at a comparative study between band, sleeve, and Roux-en-Y gastric bypass among 28,000 patients, you can see here that the BMI decrease is most substantial for gastric bypass, followed by sleeve, followed by adjustable gastric band. This is just to sort of frame what kind of weight loss you can expect over the course of 1 year. If you look at curves of weight loss, generally patients will lose pretty close to their maximum amount of weight over the course of 1 year, ultimately maybe losing slightly more over the second year, but that usually stabilizes out. This is the same study looking at the three different procedures, looking at the various medical comorbidities. So these are patients that had either complete resolution or improvement in these medical comorbidities. I'll highlight diabetes here. You can see with these procedures, there is dramatic improvement, if not resolution or cure, of many of these medical comorbidities. And these improvements become more profound as the operation becomes more profound, going from adjustable gastric band up to gastric bypass. So starting with the band, this is a picture here you can see of the adjustable gastric band, which is a silicone band that's placed around the upper stomach. It has a balloon and a port, so when you inject saline into the port that's in the subcutaneous space, that balloon causes constriction or restriction around the upper stomach. So the diameter or inlet of the stomach is decreased. This is a purely restrictive operation, so generally patients do have a sense of restriction, meaning they can't eat much. But the problem with this operation is it's not hormonal. So patients generally do not have a big change in their satiety. So what they tend to do is develop a maladaptive eating pattern where they eat things that go through the band very easily, and they tend not to lose as much weight. There was initially a big interest in the band because technically it's actually easier to perform with a very low complication rate. And so many surgeons and providers jumped on the bandwagon early. What we ultimately realized, however, is that the excess weight loss is roughly 30 to 40%. As a general benchmark, anything less than 50% in the bariatric surgical community is often defined or looked at as a failure of weight loss. Half of these bands will actually require either revision or removal for either a complication or failure of weight loss. So as I mentioned, we really abandoned this procedure at the Mayo Clinic for these reasons. Various complications of the band are erosion, roughly 2%. This image here shows the band completely eroded on endoscopic view. So you can see the band is actually intraluminally within the proximal stomach. This may actually not cause symptoms. This is a very slow process, and so patients don't really develop a gastric perforation, but they may have actually some loss of restriction there, so they may actually gain weight when this happens. The band ultimately needs to be removed. It can cause infection of the port site from bacteria seeding along the tract. Gastric prolapse is a complication that happens with the band. That's essentially a hernia where the stomach herniates underneath the band. can cause symptoms of epigastric pain, heartburn, vomiting, and in the worst case scenario, actually ischemia of the proximal stomach. Moving on to the sleeve gastrectomy. This is sort of the new kid on the block that a lot of surgeons are performing nowadays. This essentially entails removal laparoscopically of the greater curvature of the stomach, which turns the stomach into a very narrow tube. Looks like a shirt sleeve, basically. This is a restrictive operation, much like the band or the bypass, but there's also a profound hormonal component. Ghrelin is produced largely in the fundus of the stomach, which is an orexigenic hormone. And so when this part of the stomach's removed, unlike the band, patients here do experience an element of satiety. In addition, there's increased gastric emptying from the stomach, which has hormonal consequences downstream in regards to resolution of diabetes. This is a lower risk operation than the gastric bypass. It kind of falls between the band and the gastric bypass. And the excess weight loss is generally very favorable, 50-60% give or take, sometimes higher in some studies. We don't have data going much beyond 10 years as this is a newer operation. But thus far, we know this is a durable operation based on that limited data set. Complications can happen with sleeve gastrectomy just like any operation. Some of the common ones are strictures, so a narrowing of the sleeve, so food cannot pass easily, roughly 1% of the time. That can either be related to scar tissue or narrowing because the surgeon's stapled too close to the lesser curvature of the stomach, or potentially a mechanical obstruction where the sleeve can actually twist. Leak is one of the feared complications, leak along the staple line. This is actually the longest staple line in the body that any surgeon performs. The leak rate is very low, though, generally around 1%, 2% in some studies. This is generally related to an obstruction downstream so that the sleeve staple line blows out up high. The mortality rate with this is very low, less than 1%. And I'll sort of frame this and talk more about mortality and how safe these procedures actually are relative to other surgical procedures that are commonly performed. The Roux-en-Y gastric bypass, which really is the gold standard in regards to bariatric surgery, and one of the operations that we have the most data for. It's been done for a lot of years. What we do here is divide the stomach, and then we bring up what's called the Roux limb, which bypasses the stomach, the duodenum, and the proximal small intestine, or the proximal jejunum. This is restrictive in that these small gastric pouches, about 15 milliliters, so roughly the size of a walnut, so patients can't really eat much, so there is some caloric restriction that occurs. But it's also profoundly hormonal. There is a drop in ghrelin, as well as an increase in peptide YY and GLP-1, which can lead to resolution of diabetes, and actually durable resolution or amelioration of diabetes. Weight loss is generally excellent, 60 to 70%, and that is a very durable weight loss, and I'll show you some of the evidence for that. As far as bariatric procedures stack up, this is more the difficult end of the spectrum as far as technically performing these operations, and therefore the complication rate does go up, but most of these complications are around 1% or so. So leak from the gastrojejunal anastomosis, 1%. Venous thromboembolism, about 1%. Obese patients and with bariatric surgery, no exception. The risk of venous thromboembolism is there. Bleeding, 3.5%. That can be either intra-luminal within the stomach or intestine or within the peritoneal cavity. Gastrointestinal obstruction long-term from various sources. Marginal ulcers, strictures, and vitamin deficiencies. Because unlike the other operations, we're actually bypassing a part of the stomach, duodenum, and small intestine, patients can have an element of particular vitamin deficiencies, such as vitamin D, calcium, iron, among other things. So that's something that needs to be watched for. So these patients do require long-term follow-up for these reasons. So after I sort of framed all these complications, you may be wondering, well, why the heck would anyone want bariatric surgery with all these bad things that can happen? When you look at the actual safety of bariatric surgery in the lab study, which is a prospective multi-center study looking at 30-day mortality among greater than 4,000 patients, the overall mortality rate was 0.3%. So how does that sort of stack up? Let's put it into perspective. So 0.3% is far less than many of these other procedures that I've listed up here. It's somewhere on the order of a laparoscopic cholecystectomy among all comers, just to give you a general idea. Bariatric surgery, and we just went through our reaccreditation at the Mayo Clinic, is very highly regulated and has been since it started, largely related to this concept that we're taking healthy patients and subjecting them to surgery, potentially unnecessarily in some minds. And so there's been dramatic oversight. And so bariatric surgery has grown up in this culture of safety, probably much more than any other area of surgery that we've looked at. So outcomes are generally excellent with regard to complications and certainly with regard to mortality. So there has been a dramatic swing in the types of operations that are performed among bariatric surgeons. You can see there the center chunk there, the blue area, is the laparoscopic gastric bypass. That's been, probably remains the gold standard among bariatric surgery operations. But where there's been a big change is the sleeve has come about, roughly 2010 or so. It's gained in popularity and continues to increase among bariatric surgeons. You can see the band has dramatically decreased for the reasons I mentioned previously. Some centers are still performing the band, but that's certainly on the downtrend. So does this work in regards to weight loss and medical comorbidity resolution? So as I mentioned, as far as expected weight loss, the adjustable gastric band, you can expect roughly 40%, and not everyone fits into the same category. Sleeve gastrectomy, roughly 60% of excess weight lost. Gastric bypass, roughly 70% or more. Weight loss is extremely durable. Looking at this long-term study in regards to gastric bypass over the course of 14 plus years, you can see there the curve of weight loss. Most weight is lost in the first year, and it remains very, very durable over the course of 14 years. The evidence for sleeve gastrectomy is building, and it looks like the curve is about the same. So does bariatric surgery improve medical comorbidities? Absolutely it does, and I think this is one of the coolest parts about bariatric surgery is when you look at all these other things, these very sick patients that have many medical comorbidities that you all see every single day. Many of these things either improve, if not become resolved. I've highlighted here diabetes, and I want to touch on that very specifically because this is also an epidemic that we face here in the US and worldwide. So very interestingly, diabetes in particular, you can see there among bariatric surgery, 18% improved, 82% resolved. And we don't really call this a cure as much as a remission, as patients can redevelop diabetes. But that's pretty profound, 82%. Not many things we do in surgery have this great of a success rate. So what about diabetes? Why is that important? 6% of Americans have diabetes, of which 90% is type 2. That's the obesity-related diabetes. 800,000 new cases per year we face, with an estimated cost of $132 billion per year spent on treatment for diabetes. An estimated 30 million Americans in 2015 will have type 2 diabetes. If you look at this map of the CDC, this is an older image, 1990 to 2001, you can see there very easily that there's, again, a rampant increase in the rate of diabetes that goes hand in hand with obesity. Many people define this epidemic as diabesity as they go hand in hand. This is not just a U.S. problem, it's a worldwide epidemic. You can see in the U.S. certainly there's been a dramatic increase, but also in other nations and continents, they have the same problem. This is a problem that's just going to grow. Patients with a BMI greater than 40 with class 3 obesity are 3 times more likely to be diabetic. So again, goes hand in hand with obesity. 30% of patients undergoing bariatric surgery are diabetic or glucose intolerant. Type 2 diabetes goes into remission in over 85% of patients. And one of the coolest things that I see as a bariatric surgeon is that improvements are seen long before any weight loss occurs. And that's because of these hormonal components that occur. So if you take a patient with type 2 diabetes, perform, let's say, a gastric bypass as an example, many times that patient who's on metformin before the operation, for instance, will leave the hospital off of all medication with normal blood sugar. That's just a couple days after the surgery, and that's based on these hormonal things that happen independent of weight loss, which is really neat to see. So why not just medical therapy? Why is bariatric surgery such a good thing for diabetes? Medicine never cures the patient, never causes complete remission of diabetes. There are profound compliance issues, as a lot of these medications are difficult to comply with. Many will still have very poor glycemic control with medication alone and suffer progression of disease despite best medical therapy, despite all of our best intentions. And there is a very significant cost with medical therapy lifelong. Looking at a meta-analysis of 136 studies, so 22,000 patients, various bariatric surgical procedures, looking at the rate of remission of type 2 diabetes, gastric band 48%. So while weight loss is not excellent, you still have some amelioration or resolution of diabetes. Gastroplasty, or essentially sleeve gastrectomy, 68%. Gastric bypass, 84%. And biliary pancreatic diversion, which is an operation I'm not really addressing, that's 1% of our total bariatric operations, has a dramatic resolution of diabetes, 98%. So the majority of patients are cured. You can somewhat predict which patients are going to do well with regard to diabetes. If a patient has had very long-standing diabetes, high insulin level, they're probably not going to have remission or resolution of diabetes based on the fact that their beta cells are burned out. Patients who have newer onset diabetes, not on a high level of insulin, those patients tend to do quite well, so it is somewhat predictable, which is another reason to get these patients in early and treat them early before their diabetes becomes end stage. Very interestingly, surgery can actually prevent type 2 diabetes. So the Swedish obesity study, it was a prospective, non-randomized trial in Scandinavia looking at roughly 1,700 patients who underwent bariatric surgery. Compare these with roughly 1,700 matched controls. So over the course of follow-up of 10 years, 22% of the controls developed diabetes. These are obese patients that did not have diabetes 10 years prior, whereas only 6.6% of the bariatric surgical patients developed diabetes, suggesting that bariatric surgery can actually prevent the onset of type 2 diabetes. There's certainly a cost to bariatric surgery as far as a financial input. And how does that stack up to lifetime medical management for diabetes? If a patient is diagnosed with type 2 diabetes at the age of 50, the estimated medical costs, $172,000. That's 7 gastric bypasses, so certainly more than you'd spend on a single gastric bypass. If they're diagnosed with diabetes at the age of 30, that can equate to 13 gastric bypasses as far as the overall cost. Does the literature support bariatric surgery for type 2 diabetes? Absolutely it does. There is mounting evidence and currently 5 randomized controlled trials showing both better weight loss as well as amelioration of diabetes as opposed to just best medical management. I'm going to highlight one of these trials for you, which is, I'd encourage you all to look at this trial. This is sort of our gold standard trial in bariatric surgery. This is out of the Cleveland Clinic. Dr. Schauer and his group looked at bariatric surgery versus best medical management. So what they did was they randomized 150 patients, 50 in each arm, to either intensive medical therapy, and it was very intensive, and they had very good follow-up. Patients followed with endocrinologists, best medical management, weight loss therapy, behavioral therapy for diabetes, versus gastric bypass versus sleeve gastrectomy. Now, the reason why this is such a neat thing is that you can imagine in surgery, it would be extraordinarily difficult to randomize patients to medicine versus one operation versus the other. Not many patients are going to want to be randomized in that regard. They'd want to choose their own operation, if any. So this is one of the few, but a great study that we have in surgery that really is well randomized. So out of this study, if you look at the change in body mass index, you can see there medical therapy. There was some weight loss, as you'd expect, with best medical therapy, behavioral therapy, exercise, etc., dietary therapy. But it was not nearly as profound as what you see with sleeve gastrectomy or gastric bypass. In addition, there was a significant difference, as you'd expect, in weight loss between bypass and sleeve gastrectomy. This is over the course of 3 years, so weight loss did seem to be durable over that time period. Looking at hemoglobin A1C levels at 3 years, and when you look at the study, you'll see that these patients were actually quite sick with end-stage diabetes. Hemoglobin A1C, 8, 9, 10, and there was a dramatic decrease in the hemoglobin A1C over the course of 1, 2, and 3 years, which was durable. Again, much better than medical therapy alone. And actually, the ADA has endorsed bariatric surgery as a therapy for type 2 diabetes in the obese population, largely based on these studies. This is actually approaching the end of my talk. This is one of my favorite studies that I'll show you here, which is a quality of life study for Roux-en-Y gastric bypass. You look there on the screen left, you can see the U.S. norms for quality of life. This is the SF36 questionnaire. This is a validated questionnaire looking at various indices of quality of life. You can see there, for instance, bodily pain, vitality, social function, etc. The U.S. norms in red versus pre-gastric bypass obese patients. They have a dramatically decreased quality of life by comparison to U.S. norms. And then you look 6 months after bariatric surgery, after Roux-en-Y gastric bypass in particular, when weight is lost, medical comorbidities are on their way to remission, for instance. Those lines intersect now. So there is a dramatic increase in the quality of life from the obese population up to what is the U.S. norm, which is one of I think the neatest things that I see 6 months, a year, 2 years after bariatric surgery, is this really does change lives. In conclusion, obesity is an epidemic with very profound individual health as well as global and socioeconomic implications. Bariatric surgery offers a very safe and very effective treatment for obesity and the related medical comorbidities, and it should really be considered in patients with medically complicated obesity. And I'll leave these up here as I answer some questions that you guys may have in regards to how do you refer a patient for evaluation for either obesity management or specifically bariatric surgery. I want to make this very easy. You can certainly call my office at the Mayo Clinic, and we can help with that. The phone number will get you directly to our bariatric coordinator if you have a patient, and we can really take the ball and run from there. So we like to make this very, very easy. If you do have a patient that says, doc, what's up with gastric bypass? I just have some questions. We can help answer those for them. My email's up here. Feel free to email me anytime if I can help you with any of your patients. And there's also a link that I'll leave up here that can get you into a referral basis to the Mayo Clinic for bariatric surgery. But the goal here is to make it very simple for you. I'd be happy to answer any questions. Thanks for your time.
Thanks. An excellent talk. Could you answer a couple things, though? I saw where your complications were very low, and I think it was a 0.3% mortality. But I think those are probably in centers like Mayo Clinic. And in Iowa, we have a couple of hospitals that I'm aware of that are critical access hospitals that I don't know how large a volume that they do, but they don't have intensive care units. They don't even have internists on staff, let alone pulmonologists who might deal with these people. I presume a lot of these patients are at high risk for anesthesiology complications and cardiology complications. Do we know what the morbidity or mortality is in some of these critical access hospitals that have, I presume, kind of a low volume for bariatric surgery? I presume you're aware that there are some of these hospitals that are specializing in bariatric surgery. So could you describe what you think is the risk of going to a center where you don't have the support staff? Maybe you got a bariatric surgeon, but you don't have the support staff. What would be the risk in a low volume center as opposed to a high volume, high quality center?
That's a great question, and I think you touch on some very important points here. The first of which is certainly quality is definitely tied to volume. So any patient undergoing bariatric surgery should very much consider having it done by somebody who has a high volume practice. High volume remains to be defined. There is an accreditation committee, and as I mentioned, we at Mayo just got reaccredited. Actually, yesterday we had our site visit for that. But I would recommend if you're going to refer a patient anywhere, refer them certainly to a place that's accredited by the ASMBS for performing bariatric surgery. There's a high level of oversight with regard to centers of excellence for bariatric surgery that looks at quality. The other point you touched on is in regards to multidisciplinary approach and having the resources available to care for these very sick patients, because they are very often very, very sick with end-stage diabetes and all the manifestations that come along with that, obstructive sleep apnea, hypoventilation syndrome, and all these things that make them very high risk for anesthesia and post-operatively. So certainly, in my opinion, these operations, especially with the more complex patients, should be done in centers that have the resources to care for these patients with a high level of excellence. Absolutely, there are centers, bariatric surgery centers, so to speak, that are performing adjustable gastric bands, and many of them every year, and they're really centers to make money. So they're cycling these patients through, not following them post-operatively with a high level of revisional surgery necessary or complication rate, and I think that's very unfortunate. These operations are lucrative, and I think that's likely why that's done, but absolutely, I agree with your points.
Yeah, just one other quick question. Seeing how cost-effective this is, in a 50-year-old, you could pay for 7 gastric surgeries for the savings of that patient over the rest of their life. Do you have much pushback from insurance companies in approving this? And does Medicaid tend to approve this as often as you'd like to? So is there a difference in insurance companies and Medicaid as far as the approval?
Good question. There absolutely is a difference. Actually, Medicaid and Medicare are one of the easier insurance providers to have a patient qualified for bariatric surgery. Medicare, for instance, doesn't really require a rigorous preoperative evaluation process. They can be sort of shuttled through, which I find ironic. We still put them through the same process that all our patients go through. Most private insurance providers do mandate, A, that they meet the NIH criteria, so BMI greater than 35 with one medical comorbidity or greater than 40. In addition, these patients are required to go through a very rigorous multidisciplinary workup, which involves dietitian, nutritionist, psychologist, endocrinologist, surgeon. They get a sleep study for obstructive sleep apnea. So absolutely, there is a difference among insurance providers to some degree. Regardless, based on trying to increase the quality, all our patients who come through get the same preoperative evaluation. And then they get roughly 3 to 6 months of education. And I say 3 to 6 months because it's largely based on how aggressive the patient is with getting all these appointments done. But they go through something we call the LEARN program, where they learn about these various operations, how their dietary habits are going to change post-operatively, learn about what it means to be on vitamin D with calcium, or calcium with vitamin D, multivitamins with iron, what can happen if they skip their calcium for months, etc.
I may have been sleeping, but was there a little thing at the beginning about what is percentage estimated weight loss? What does that mean? You look at a person who's 400 pounds and you estimate what their weight loss will be with the procedure, and then the percentage is how close you came to that? Is that what that means? No,
gotcha. Yeah, I should have been more clear with that. So EWL is, and this is generally the way, at least in the bariatric surgery community, we define weight loss as percentage excess weight loss. Okay. So one way to look at it is BMI less than 25 is normal, so that's the standard. If the patient has a BMI of 35, they have an excess weight of 10 BMI points. So you look at 50% of excess weight would be 5 BMI points, for instance.
Okay.
Does that make sense?
Yeah, and if you don't mind, I'd like you to go back and ruminate a little bit more about the cause of obesity. Yeah. It just seems weird because we've had no real change in genetics. I mean, genetics haven't changed, and then the other 2 points you made was access to diet, and and there's all this trendy stuff about the microbiome playing a role in eating and nutrition and diet. Do you want to ruminate on that a little bit? Don't go too long, but
I'd love to. And this is all a caveat. This is all speculation, of course. The science behind this is very fascinating and just emerging. But I think we evolved in a time where McDonald's didn't exist, where it was difficult for us to obtain high caloric density foods. And so if there was some sort of high caloric density food source, of course we were programmed to eat that up, to fill ourselves up with it, because we may not see that again for a long time. Unfortunately, those genetics persist, and we crave the things that are not necessarily healthy for us. I mean, McDonald's tastes great to us, which is an unfortunate circumstance, because it'd be great if broccoli tasted great to all of us. That's not the case, though. So I think genetics does play a factor, despite that it hasn't changed. We still have that genetic subset of people, which most of us sort of have those cravings, and then you take that patient population and drop them into a world where there's a McDonald's on every corner, and the iPad is in front of us, and we're not exercising regularly. We have all these distractions from things that are generally healthy. I think that sets us up for failure for some degree, and it makes it very difficult to maintain a durable weight loss through just standard diet and exercise. And that's been shown in multiple studies that patients can lose weight through diet and exercise and lifestyle modification, but it is absolutely not durable, unfortunately. That's kind of my 2 cents. But there is a lot of science and emerging science with regard to, as you mentioned, the microbiome, which is absolutely fascinating. One of the things we're actually studying at Mayo is, after a gastric bypass, what happens to the intestinal flora? Does it change? Does that have a consequence with regard to diabetes? And I think all these things, the science we're learning based on these operations, will ultimately eventually probably make bariatric surgery futile, and that'd be a wonderful thing for patients altogether if we had a pill that would solve obesity, but we're not there yet. Hopefully we'll get there.
As you mentioned in your lecture, we're seeing more and more obesity in the young and in the adolescents and children and adolescents, and they're developing type 2 diabetes as adolescents. Do you have an age cutoff for when you would consider doing a gastric bypass, or is that something they're doing pediatric now?
Yeah, a lot of places are, and we have a program at the Mayo Clinic. We haven't done that many patients. That's largely related to the fact that of all the patients that are referred to us for bariatric surgery among the adolescent population, we turn down the majority of those patients. We have a very rigorous selection criteria, which I think most places should. As far as age criteria, there's not really a cutoff per se. We haven't done anyone younger than 13 years at Mayo. One of our selection criteria is the patient has to have an understanding of what obesity is, what the surgery will do to them, what the consequences are, and they have to express that to the surgeon, the endocrinologist, the psychologist. They have to have a very supportive family. They have to have a very compliant family. They're not missing appointments, et cetera. And these patients that ultimately do end up with a bariatric surgical procedure are extraordinarily sick. They're not your standard patient with a BMI of greater than 40. These are patients that have severe end-stage obstructive sleep apnea, pseudotumor cerebri, severe end-stage type 2 diabetes, for instance. So very highly selected group.
I have a couple questions. First off, what is the recovery time for the various surgeries? Recovery in the scope of returning back to work full time. Second, the huge amount of excess skin. Are surgeries covered for that, or are those still considered largely cosmetic?
Good question. So in regards to recovery, patients, just to sort of frame your question a couple ways, they're usually in the hospital for 2 nights and then leave the hospital. Generally, time off of work, for instance, usually about 4 weeks. And it's not because they're recovering from surgery per se, incisions and such. It's largely related to the fact they're in this very catabolic phase right after surgery and losing weight rapidly. And a lot of patients feel quite fatigued after this operation for a while, so they're not quite ready to go back to work. Most patients about 4 weeks, though. Some patients require a little bit longer. Sorry, what was your second question was? Right. Yeah, so generally we wait about 1 to 2 years depending on who you ask. I prefer to wait 2 years before sending an evaluation for a plastic surgeon for skin removal, and that's largely based on the weight loss curve. You'd wait for an operation to happen and they lose more weight, for instance. Is it covered by insurance? Frequently it is, but it has to be because of medical need, not because of a cosmetic need, and generally we can get that pushed through with regard to most of these patients have rashes, for instance, or an infection of some sort. If that's documented, so I ask patients to take a photograph of that if it happens, most insurance providers will cover that. Good question.
How many gastric bypasses are you doing at the Mayo Clinic per year versus the sleeve process?
We're still predominantly gastric bypass, and that's largely because we're strong believers in that operation, and we don't like to switch unless there's a profound preponderance of evidence suggesting that one thing's better than the other. We are doing roughly 200 or so gastric bypasses a year, probably roughly 50 sleeve gastrectomies a year, and again, our selection criteria for sleeve is probably a little bit more rigorous than most institutions. For instance, a lot of obese patients have gastroesophageal reflux. The sleeve gastrectomy, there is some evidence that reflux can be worse after a sleeve because it's a high-pressure system. So a lot of surgeons would offer any patient a sleeve gastrectomy. We're somewhat more rigorous with regard to gastroesophageal reflux, for instance. But ultimately, I think that's going to I think the numbers are increasing. We are seeing more patients coming in asking for the sleeve gastrectomy because they know somebody who's had it and they've done very well. They read that it's a slightly safer operation, which it is all told. And they see the evidence mounting that the weight loss is very durable with the sleeve. One caveat is the sleeve is, if you think about it, the only non-reversible bariatric surgical procedure. Once you take out that part of the stomach, there's no going back. Thank you kindly for your time and happy holidays.